Good evening to one all present here. Today the topic is about differentiating between the types of retinal detachments. I am presenter Dr. G. Madhumitha and moderator of the class is Dr. Raghulnadhan sir. The indices of the class are few points just about the anatomy and physiology of retina and what is the definition of retinal detachment, types of retinal detachment, and few case discussions about each type and pathogenesis of each RD and differential diagnosis on some take home points. Now, about the definition of retinal detachment. What is retinal detachment? It is nothing but it's a separation of the neurosensory retina from the retinal pigment epithelium. Here, as you know, these are the 10 layers of the retina, and the outermost layer is the retinal pigment epithelium, and other inner 9 layers are called as the neurosensory retina. When the separation of these 9 layers from the pigment retinal epithelium, that is, the detachment occurs here, this is called as the retinal detachment. And why it occurs only at that particular area more common is that the development is the main reason for it. We know this retina is developed from the optic vesicle, and this optic vesicle has 2 layers, that is outer and the inner layer. The outer layer forms the outer retinal pigment epithelium, and all the inner 9 layers are developed from the inner layer of the optic vesicle. Hence, we get the detachment more commonly at this site. This is the OCT image, that is optical coherence tomography image of the layers of the retina. Just to have an idea, I will tell which are some hyperreflective membranes which we remember so that we will know others are the hyperreflective membranes. We can see this is the inner limiting membrane, innermost layer, and the nerve fiber layer which are hyperreflective. And this both outer and the inner plexiform layers, it appears to be hyperreflective layer. And this is the less hyperreflective layer here you are seeing is the external limiting membrane. Below that is the inner outer photoreceptor segment which is hyperreflective, and RPE interdigitations and RPE Brooks membrane complex also is a hyperreflective zone. These are some of the factors which maintain the retinal attachment normally. The factors are the physical factor which helps the retina to be attached are the pressure difference between the interphotoreceptor matrix. Anatomical factors are the intact vitreous which pushes the retina and it keeps the retina in attached state, and intact the retinal pigment epithelium. The metabolic factors are the RPE pump mechanism which constantly pumps the fluid out. This helps to maintain the retina attached. And normally the retina is maintained in the dehydrated state. This is because of the retinal barriers. As we know, there are 2 retinal barriers. One is inner retinal barrier and the outer retinal barrier. The inner retinal barrier is nothing but it is formed by the retinal capillary endothelial cells, and outer retinal barrier is at the level of the retinal pigment epithelium. This RPE helps to maintain constant outflow movement of the fluid and it keeps the retina in the dehydrated state. The factors which cause this are that is the active transport mechanisms in the retinal pigment epithelium and high oncotic pressure force which is seen higher side in the choroidal side, and the hydrostatic forces. These are all mechanisms keeps the retina in the dehydrated state by pumping the fluid out. So the fluid from there are 3 outflow pathways, how the fluid is pumped from either vitreous or in the retinal spaces outside of the eye. So first the fluid anything in the vitreous or between the retinal layers, it is pumped into the RPE, and from RPE by pump mechanisms, it enters the choroid. Then from the choroid by the uveoscleral outflow, that is through the choroidal vortex veins, it exits out to the sclera. Then through the emissary channels, it exits out of the eye. What are the 3 potential sources of fluid that makes the fluid bit accumulated between the retinal layers are, that is either the liquefied vitreous and fluid from the retinal vessels and the choroidal vessels. Now we will go into the clinical presentation of RD, retinal detachment. First, the patient complains of sudden onset.
Yeah. Madhumitha, hold on. So what are the other causes of painless vision loss and gradual onset? To be very precise here. So if someone asks you in a viva, so how do you proceed? So you cannot just go about telling some names. So you have to classify your answer. So you can start with say vascular causes like that. Okay. So maybe can you give me some vascular causes?
Here
yeah,
we
yeah,
go. Branch retinal vein occlusion.
yeah,
Then it's for sudden vitreous hemorrhage,
yeah. I agree. Yeah.
non-arthritic.
Okay. So those are the neurological causes,
Yes.
right? Yeah. Yeah. What are the other causes? Can anyone help her out? Any of your can pass the mic? Who has the mic? Yeah. Yeah. Proceed. Yeah. The mic is on. Mic. Yeah. Turn on your mic, please.
I mean, one way to go about it is we go anatomically from the cornea back to the, or the other way is most common to least common. So if we take anatomically, uh, then cornea it could be uh, dystrophies or degenerations.
Okay.
Then iris lens में age related cataract is also
Okay.
a cause for gradual.
Okay.
Then refractive errors.
So, okay. So we are talking about the sudden
Not
onset.
sudden.
Yeah.
So one is retinal detachment. The other is artery.
Yeah.
Central
Yeah.
retinal artery
That's right. That's right.
occlusion.
Yeah. So yeah. So what are the miscellaneous causes? Can you name some of them? Okay. So what books are you following? Like I wanted to ask the PG, the Akash, what do you read? Like if someone asks you, so where do you answer mostly? Is it like you have something like that, or like you follow some books?
Predominantly Kansky.
Kansky. Okay. So what does Kansky say? So regarding the sudden painless DOB. So does it have any classification, or is it just like
No, I don't think so. It has a classification for that.
okay? So I think in exams that's important. So you must know how to the way to present. Okay. So yeah, proceed, Madhumitha.
Then next complaints of flashes, which is because of the production of fast beams, and floaters. The floaters, it may be either single or multiple, or it may be small or large. So it can give some clue to the diagnosis. If the patient complains of floater with sudden and large floater, it may be the posterior vitreous detachment, which that is V string we can see in IDO. Then if it is a numerous curvilinear floaters, then that may be a vitreous degeneration. If it is there's a numerous tiny black spots, then it's a vitreous hemorrhage.
Yeah, these are textbook definitions, but not always. Okay, can be interchangeable as well. Yeah, proceed, please.
Then other complaints may be curtain falling over the vision and visual field loss. Then the signs of retinal detachments are the affected eye, the retinal detachment eye, there may be RIPD may be present.
Yeah, hold on. So what is RAPD? How do you check it? Next person, the one who has the mic. Kindly explain, like.
Sir, RAPD refers to relative afferent pupillary defect, and here anywhere between the optic nerve till the nucleus, there could be any lesion, and that might result in RAPD.
How do we examine RAPD?
So we have the swinging torchlight test for
Okay.
it.
Okay.
So we have to the room should be a dim lit room, and the patient should be seeing somewhere, should be fixating it at a distant point, and we have to ask the patient to look straight and then flash the torch from one eye to the other.
So what is the source of the light?
It should be a diffuse light,
Hmm.
such as indirect ophthalmoscope
Okay.
light, and we should be swinging the torch or the light from one eye to the other,
Okay.
such that the initially if we start swinging from right to the left, we have to see if there's constriction in the right followed by constriction in the left.
Yeah.
But if at all, if there is a afferent defect in the left eye, so that time what happens is when we shift the source of light from right to left, then the light will dilate rather than constrict.
Okay.
So that is
Okay, sure.
the positive.
Who else is there? Venu Asni is there? What are the grades of RAPD?
So there are totally 5 grades of RAPD.
Yeah.
Grade 1 is constriction, and then there's a momentary stall.
No, stall is grade 2. Yeah. Anyone else can help her out?
And so
Who's
constriction,
answering?
then dilatation, then
Yeah, yeah.
that's grade 1. Grade
Okay.
2 is stall. Like grade 3 is dilatation.
It's not just stall, I think.
Stall followed by constriction.
No. Yeah. That's right. Yeah. What about 3? Yeah.
So grade 3 is immediate
Yeah,
pupillary dilatation
Yeah,
to
yeah,
the
yeah.
light source.
That's right.
Grade 4 is immediate dilatation after 6 seconds of
Yes.
illumination, and
That's right.
grade 5 is immediate pupillary dilatation with no constriction.
Exactly. So how do you grade this RAPD? Is there any measurements to grade this? Is there any, Akash? Sorry. Yeah, it's neutral density filter. That's right. Please proceed, Madhumitha.
Yes. Intraocular pressure, it will be low. That's mainly in case of rhegmatogenous RD. It is said that there may be at least 5 mm Hg lower than that of the other eye. And next one is the fall in the intraocular pressure. In the early stage, it is mainly due to the inflammation and reduction in the aqueous production, whereas the prolonged hypotony, that is over longer period, it is due to because of the seeping of fluid into the brakes. Then Schaffer's sign, it is nothing but called as tobacco dusting. It is a pathognomic of the rhegmatogenous RD. You can see the pigment-like deposits, pigment-like dot-like structures seen in the anterior vitreous space. This is because nothing but the RPE migrates from through the brake into the anterior vitreous space. It is seen like pigments in the anterior vitreous space. This is called as Schaffer's sign or tobacco dusting seen in rhegmatogenous RD. And other signs are there will be a loss of red reflex, and on indirect ophthalmoscopy examination, the retina, it may be elevated, and in case of rhegmatogenous RD, retinal breaks can be seen. Can someone tell what is Schwartz syndrome in retinal detachment?
Sir, in Schwartz-Matzau syndrome, there is a high IOP instead of a low IOP in RD, and that's when the photoreceptor segments come and block the aqueous outflow, and it's mostly in chronic RDs.
Not really. You cannot definitely say in such. Yes, it's a transient thing. One thing is about, and you not actively treat such things because it's just a kind of inflammatory thing that's gonna happen. So just control the IOP and treat the actual cause. So that's how we must go about it. Proceed, please.
Then we'll go into types of RD. The types of RD, that is, first one is a rhegmatogenous retinal detachment. Here you can see there is a retinal detachment and there is a presence of a break. This rhegmatogenous retinal detachment. And second one, you can see there is a tractional membrane which is pulling the retina, resulting in the retinal detachment. This is tractional retinal detachment. And here there is some underlying pathology in the choroid, which results in the retinal detachment. This is a exudative retinal detachment. Now case discussion. Case 1. A 55-year-old female came with the complaints of sudden onset painless diminution of vision in the left eye for past 1 month, and she had no any history of flashes, floaters, no history of trauma, no history of any recurrent redness or eye pain, and no history of fever noted. Past ocular history of both eye cataract surgery done 12 years back, no history of any capsulotomy done. Systemic history.
One second. So post cataract surgery, so you must always mention whether the vision was better or the vision was worse even after cataract surgery. That gives an important finding, because the RD may be pre-existing, or the RD would have happened post an eventful cataract surgery. So you must try to differentiate between these two. And why history of yak caps? Anyone? Okay. How come? What's the mechanism? No. What exactly does yak caps do to the vitreous face? That's right. Yeah. Please proceed.
She had no any history of systemic illness and not on any medication. No similar family history and no history of any
Yeah,
allergy.
hold on. So, what are the systemic? So, why did you ask for systemic history? And what is the importance of family history of RD?
So diabetes, fiber.
No, not really. Not really. What is the? I'm asking a specific question. So, what is the family history? Significance of family history in a patient with rheumatogenic RD? Okay, myopia. Yes, I do. I agree. What else? So, what are the ocular conditions that can predispose to retinal detachment?
So stickler syndrome.
Yeah, that's right. Sticklers. Yeah, that's right. So Marfan's, yes, I do agree. So that comes more like a systemic thing. So yeah, syndromic is yeah. Anything else? Any other syndromes? I just want to. Okay, yeah, I agree. Anything else? Sorry, Wagner's. Yes, Wagner's. Anything else, Doctor? Okay, yeah, Will Marchesani. That's right. So autosomal dominant vitreoretinopathies. Those can also cause, RD. Family history can be there in such cases. Okay. Yeah, FEBL. Very good point. That's right. And systemic history, if the patient is so
So history of renal failure and
okay.
malignant hypertension or pre-eclampsia in women.
Not really, because we are talking about rheumatogenic RD. So those histories are very significant in exudative. Yeah.
Okay.
Yeah. Proceed.
Clinical examination. The best corrected visual acuity in the right eye was 6.6 by 7.5 and near vision is N6. Left eye it was hand movements less than N36. PL was present and accurate. Refraction in the right eye, the refractive error was minus 3.25 diopters per sphere, minus 1.5 diopters cylinder at 110 axis. On examination, right eye, his works was ortho. Extraocular movements was full and free. There is no any abnormal head posture. Pupillary examination, the pupil was regular, reacting to light, and no RAPD is noted. On slit lamp examination, the lid and adnexa are found to be normal. Conjunctiva is normal. Cornea is clear in the both eyes. Anterior chamber was quiet and VH grading was 4. Iris color and pattern was normal. Both eye lens status was PCIOL. And intraocular pressure in the right eye is 18 mm Hg and in the left eye is 3 mm Hg. This is the optos image of the right eye.
Hold on. Anyone wants to try? Exam going. Who's the third one, Akash? Who's the third one? She's not there. Can you try?
This is pseudo color image of the pseudo color fundus photograph of the right eye, showing media is clear, disc is round, average sized, round in shape, with a CDR of 0.2 to 0.3 with a healthy neuroretinal rim, no neuro RNFL defects. There is a black discoloration in the peripheral retina at 12 o'clock, most probably a lattice. In the second photo, there is a blackish discoloration of the peripheral retina at from 6 o'clock to 8 o'clock.
Okay. So, what do you see within that blackish discoloration? Can you describe more? There are no holes actually. So, I examined this patient. There were no holes exactly. It's just a degeneration. Peripheral chorioretinal atrophy was there. There were no holes in that case. So, it's a what is it? It's a lattice, right?
Yeah, yes,
so, can you define a lattice? exact textbook definition. Can you? So what? No, that is okay. How do you describe lattice, Madhumitha? Can you help me out?
It is a cigar-shaped lesion.
Okay.
It is usually located in the equatorial region.
Yeah.
And there will be hyalinized vessels, crisscross vessels
Yeah.
over there,
Yeah.
and
Yeah.
along with the thinning of the retina over it.
Yeah, yeah. So that's right. And yes, with or without
With
retinal adhesions. That's right. So the top one that you see, it's just a CRA patch.
Patch.
So clinically, yes, I do agree. You cannot really comment upon lattice, in optos, because as we all know, it's not a real color that we are looking at. So it's a CRA patch, and the inferior one is definitely a lattice. Yeah. And apart from this, we also saw. Can you point out that thing which is below the vessel, below the disc, just below the disc? So what is that? Yeah, what is that? So what's the location of that lesion? Is it over the retina or under the retina? Can you see that, Madhumitha? The one which you have pointed out. Yeah, exactly. What is that? So, yeah, it's in the vitreous phase. Yeah, that's right. That's right. Okay, proceed. But not really. But yes. But if it's the classes for the PGs. So if someone asks in exams, better to give this answer. Okay. But most likely, if you do an OCT in these cases and see, yes, you can see those hyalinized vessels. Okay. Yeah. Please proceed.
So the opto pseudocolor image of the left eye, here you can here the disc media appears to be little hazy. Then the disc is not much clear, it's not seen, and macula is not appearing. Here you can see the retina is elevated and it is detached with corrugated surface inferiorly, and here you can see a break, which this break lies at the level of second order vessels, and it is located at the 1.5 clock hours. And this break, it is seen in the superior temporal quadrant at the 1.5 clock hours, and here is the corrugated elevated retina, and it is macula involving. You cannot see the macula clearly. And to find whether there is underlying any choroidal detachment or not, we have taken an ultrasound. Clinically, it's not appearing like there is a choroidal detachment, but we have done ultrasound to confirm the choroidal detachment. This is B-scan image of the left eye. Here you can see the high reflective membrane. Here there is an IOL reverberation echoes with some dot echoes seen in the vitreous, and this is the hyperreflective membrane. You can see the corresponding spike here, high reflective spike. This is the retina. This detached membrane is the retina, and you can see the SRF below it. Then here inferiorly at this level and here superiorly, you can see there is a detachment of the choroid. So in the ultrasound, we confirmed that there was a choroidal detachment.
Yeah, hold on. So what are the grades of vitreous haze? So what is EVS classification, Venusni? So there is one EVS grading for quantitating, or how to put it, to say there is vitreous, that media is clear or media is bad. Any idea? Yeah. Proceed. Get the mic. Take the mic. Yeah. Can use this. Yeah. So what is EVS stands for? So endophthalmitis vitrectomy study. Okay. Please proceed. Give me the answer.
Based upon the order of the vessel that is visible, the higher grade of vitreous haze is when we are not able to see the first order. So I don't exactly know the classification.
Anyone can help her out? Anyone else? Maybe Kavya or Asta. Can you give the answer? Anyone else? So can you help her out?
There are 5 grades, sir. Grade 1, there is the 612 view of the retina is seen. In grade 2, the second
So,
order
612 view of the retina, or what else you call it? you are able to see all of the retinal vessels. Okay, so
Yes, sir.
yeah,
First order every vessel
yes,
very clearly.
yeah.
And second order in grade 2, second order vessels are seen. In grade 3, second we can see some the vessels presence, but it's not the second order vessels clearly. Then in grade 4, vessels are not seen, only red reflex is seen. In grade 5, even the red reflex cannot be seen.
Yeah. So the 6/12th view of the retina, it indirectly indicates that the media clarity is good. Yeah. So yeah, please proceed. What you can do is you can skip the treatment part. Anyways, we are going to discuss it for the next session.
Yes.
Please proceed. Yeah, yeah. Tell me. So see, so first of all, Optos is just there. It's sitting right there just to guide our diagnosis. Other than that, so it's nothing comparable to your clinical acumen. So unless you examine the patient, even if you are gonna look at this image, okay, if someone is giving you this image in your Viva, so you cannot sure shot tell that that is the only break lying over there, because I examined the case and I know there was one more break inferiorly. Okay, so yeah, so I think that answers your question. Okay.
And the final diagnosis is the patient has left eye pseudophakic with macula of total retinal detachment with a single break seen over the superior-temporal quadrant with early PVR changes. The grades of PVR comes under the grade
Yeah. Proceed.
B. The grades of PVR we will discuss in the later
Yeah.
slides.
For the sake of time constraints, we can shift to the second case.
Okay, sir.
So patient underwent vitrectomy for did a vitrectomy for this case.
Left eye here underwent vitrectomy,
Yeah.
belt buckle,
Can proceed.
laser and SO.
Next.
After that, post-op 6 weeks, the vision was improved to 6/24.
Yeah, sure. Please proceed to the next case.
Okay, sir.
I think you can skip this part.
Okay.
Yeah. It's okay. 1 second. You can just show the tabular column. Please come back. Go back. Yeah. Just this one.
There's difference between retinoschisis and the rhegmatogenous RD because both suddenly we can mistaken for retinoschisis. Retinoschisis is nothing but it's the separation within the neurosensory retina, whereas the rhegmatogenous RD, the separation is between the neurosensory retina and the retinal pigment epithelium. Retinoschisis, the location, this is the retinoschisis image. This retinoschisis, the most common location in the temporal, that it may be either the superior temporal or the infratemporal location, whereas rhegmatogenous RD, more common location is the superior, maybe supratemporal or supranasal, followed by infratemporal and the infranasal quadrants. The most common site for rhegmatogenous RD is the supratemporal quadrant because the most of the retinal degenerations and causes which causes the rhegmatogenous RD is found to be more common in the superior-temporal quadrant. So the most common site is superior-temporal. The surface, if you see the retinoschisis, the surface here you can see that it appears very smooth, whereas here the surface is very much corrugated. Usually it is said that in retinoschisis the hemorrhage and pigments are absent, but it may also occur in case a complication of the retinoschisis. But in case of rhegmatogenous RD, you can see the pigments and the hemorrhage is present. Scotoma, in retinoschisis, patient comes with the complaints of absolute scotoma, whereas in case of rhegmatogenous RD, it is a relative scotoma. Can someone tell what is absolute and relative scotoma? What is absolute scotoma? First year someone?
You can give the answer.
Okay. Absolute scotoma is the patient sees in his field of vision there is a scotoma area, black area which is not seen. That is the absolute scotoma. Whereas in case of relative scotoma, the patient doesn't know that there is a scotoma. He cannot see a field of area. But we diagnose only when we examine the HVF. Photocoagulation, it responds in case of retinoschisis, whereas in rhegmatogenous RD it does not respond. The OCT finding is, this is the OCT image of the retinoschisis. Here you can see the splitting of the neurosensory layers, and generally subretinal fluid will not be there here. In rhegmatogenous RD, you can see this is the splitting between the neurosensory retina and the retinal pigment epithelium, and there is a SRF collection here. This ultrasound finding in the retina cases, the same. It is smooth and it will be thin layer because it is between the neurosensory layers. But the regmatogenous RD, it will be the high reflective thick membrane when compared to retina cases. In retina cases, it is smooth, thin, hyper reflective, and dome shaped membrane. And we know the regmatogenous RD, the attachment usually seen to the optic disc. But whereas in retina cases, we cannot see the attachment to the optic disc.
Yeah. So what are the investigations to confirm the presence of retinal detachment? Akash, if this is the question that's asked in your Viva, what's the answer? I'm talking about regmatogenous component of RD. So what investigations do it's a must do to confirm the presence of reg RD?
Sir, indirect ophthalmoscopy. Firstly,
Yeah.
ultrasound, B scan.
Okay. So Akash, I'll repeat the question for you. So what are the sure shot investigations that you must do to confirm the presence of regmatogenous retinal detachment? So what I mean to say is, can you operate a patient with reg RD without investigating? Yes. See, regmatogenous retinal detachment is a clinical diagnosis. So you need not wait for any investigations unless it's absolutely indicated. Not wait. Suppose if the media is very poor, so in that case, yes, you may tend to wait for investigations, but otherwise, it's a clinical diagnosis. You did not require any investigations. You not wait for any investigations to operate on a patient with regarding unless if there is any serious indications. Okay, and yeah, proceed. Can proceed to the next case.
Yes.
Yeah, you can just touch upon that.
These are the signs of chronic RD. In case of chronic long-standing RD, the surface may become smooth, so it may be mistaken for some other. Because in regmatogenous RD normally we see a corrugated surface, but over a period of time it becomes smooth surface, and we can see the presence of demarcation line in case of chronic RD. The demarcation line here you can see it is pigmented, but here it is non-pigmented. Maybe either way, the pigmentation is because of the pigment epithelial proliferation. This demarcation line prevents the further spread of SRF fluid outside, and the presence of intraretinal cyst you can see here. This is also a sign of chronic RD.
Yeah, and also subretinal fibrosis and subretinal gliosis. Yes, yeah. So why does undulating form of acute RD becomes smooth in a chronic RD? Or you can put it in another way. So in acute RD you see all those corrugations, whereas in your exudative type of RD you don't see such things. What's the reason? Something to do with the RP pump? Anything? So what is the why
RP pump is affected in case of exudative.
Yeah, that's correct.
That's
yeah. Sure. Can proceed to the next case.
Yes. The case 2, a 25-year-old male came with the chief complaints of sudden onset painless diminution of vision for past 1 month. Then he had a history of trauma to the left eye with mace 1 month back. No history of flashes or photos. The other history was asked retrospectively once the diagnosis were made to confirm the other causes causing this RD. So there was no history of any recurrent redness or eye pain, no history of steroid intake or any topical steroids, no history of any tuberculosis or contact with tuberculosis, and no history of tinnitus.
History of joint pain, I think, is missing in this. Yes, yeah. So what are the significance of all these histories? Can anyone, like, who has the mic? Yeah. So what is the importance of fever in this case? So obviously we know it's going to be an exudative RD. So I'm revealing it. So what's the importance of history of fever in such cases?
So inflammatory causes, if there is any systemic inflammatory cause that is leading to, so in case if there is systemic vasculitis or something like that.
Okay, sure. I agree. Next person. So what's the importance of, eye pain you can skip. You can someone tell about the steroid thing?
So
Yes, sir.
steroid usually in CSC or
Yeah, that's right. That's right. And of course, most of these patients will be on some kind of immunosuppressants. So that history, yes, that makes a sense. What about next history? Next person, please. So it's straightforward. Right? What does TB cause? Really? Okay, fine. So importance of tinnitus. What's the importance of tinnitus? Yeah, VKH. Yeah. Any other histories missing in this case? Yes, Dr. BNB, would you like to comment?
So as you said, joint pain, the history of trauma is something important. History of trauma is something that we take to rule out if it is if it is sympathetic ophthalmia and VKH both have similar presentations, but history of trauma, even after blunt trauma, there are reports of sympathetic ophthalmia. So history of trauma something, history of recurrent redness. Why do we ask for repeated history of recurrent redness? Because most of the uveitis conditions have like has a remission phase, plateau phase, and then again it increases. So if the patient has recurrent history of redness, there are certain diseases which classically has a on and off period. So to classify, we take all these histories.
Apart from this history, you can also ask, history of any skin rashes. So yeah, that's important. So do you know any condition where skin rashes are associated with uveitis? Yeah, I agree. I yes. Anything else?
Sarcoidosis.
Sorry,
Sarcoidosis.
sarcoid. Okay. Which skin lesions?
So
So
it has those nodules on the skin.
so are you talking about erythema nodosum?
Yes, sir.
Oh, yeah. So the answer which I was looking for is erythema nodosum. So you can look for those lesions. So and apart from those, can syphilis we have to see for such lesions?
Yes.
Yeah, and syphilis as well. Okay. Yeah, and of course vitiligo. You rightly mentioned. Yeah. Proceed.
Past ocular history, he had a history of trauma to the eye with mace 1 month back, for which he was treated locally with antibiotics, lubricants, and natamycin. History of both eyes, cataract surgery has been done. Both eye he has history of congenital cataract, and he has low vision since childhood. Right eye cataract surgery was done 2007, and history of right eye capsulotomy was done thrice, and he is on timolol eye drops twice daily. Systemic history, no history of any other systemic illness, not on any medication, and no any allergic history. On clinical examination, the best corrected visual acuity in the right eye was counting fingers at 1 meter, and near vision is less than N36. In left eye, counting fingers at 50 centimeters, and near vision is less than N36. On examination, the Hissberg test was ortho, extraocular movements was free and full, no abnormal head posture. Pupil examination was regular reacting, but it is sluggish reacting. There is no any RAPD. Then this is the slit lamp image showing the anterior segment of right eye. It was normal, and it was here you can see the PCIOL, right eye operated with the optic capture seen superiorly, and left eye anterior segment was normal with the cataract, zonal cataract, congenital cataract seen in the left eye. And anterior vitreous phase on slit lamp examination was found to be normal, no cells or anything is noted. Intraocular pressure on the right eye is 10 mmHg and left eye is 15 mmHg. This is the fundus examination of the right eye shows there is an the media was mildly clear, the clear only. There was SRF packets noted in the posterior pole, and exudates was noted at the mid-peripheral region, and RPA alterations are also noted in the right eye, and disc appear to be normal in the right eye. Whereas in the left eye, there is a disc was hyperemic and disc edema was noted, along with the SRF packets located in the posterior pole and also some inferiorly. And exudates are seen all over the mid-peripheral area, and inferiorly you can see subretinal deposits as well as a bullous retinal detachment is seen inferiorly.
Yeah, hold on. So how do we examine vitreous cells?
Slit lamp.
Okay. Yeah. Can you give me the... Yeah. Can you demonstrate how it's done?
Sir, in a dimly lit room, we make a 1 by 1 square of illumination, and then we count the number of cells we can see in the anterior vitreous space.
So how do we reach there?
Increase magnification, sir, and focus on the AVF.
So
behind the
where do
lens.
you exactly look at?
Behind the lens. Behind the lens. Or IOL.
Push the joystick.
Yes.
So, sun classification for anterior cells is 1:1, and sun classification for anterior vitreous phase is actually 1.5:1.5. So, both sun classification for anterior and for anterior vitreous phase, you can remember it for exam sake. But practically, when you go and examine, it is a very subjective thing. What I feel it is 1 plus, you may feel it is 2 plus. So it is not just for AC cells, it is also for AVF cells. But the point is, you should look at the AVF. Without in your regular slit lamp examination, starting from cornea, you have to go. I mean, just like how you are telling lens. After lens, you don't tell anything. So, but only when you look into the anterior vitreous phase, even the pathognomonic, whatever tobacco dusting and all those things, it is only when you look at the anterior vitreous phase you will say whether those are cells, whether they are active cells, whether they are old cells, whether they are pigments, or whether they are tobacco dusting, whether it is quiet or not quiet. So all these things you will get only on chronically looking at. I mean, you should keep on looking. It is just like doing gonioscopy. You keep on doing, then your findings will come right. So it is not going to come in one day. So keep only when you keep looking at anterior vitreous phase, you will be able to tell those things. In this diagram, there are two things. One is the blue component, another one is the yellow component. I'm talking in very like basic thing, so that you people can understand. So in the starting of this presentation, if you have seen, she would have told about leakage from the retinal, leakage from the choroidal, and there is accumulation of fluid in different levels. Okay, so when you have the exudative RD component is actually the yellow part. So when you have the increased leakage of vessels, which the RP cannot compensate, which the RP cannot revert back. The RP's work is to keep the neurosensory retina dry. Okay, so when the when there is fluid overload into the neurosensory retina, which is more than what the RP can take out, then the exudative RD forms. So exudative RD is the blue component. When there is when there is exudation happening, and when there is not apart from what this what the fluid comes, you also get proteins and other things which is getting out of the retinal vessels, the loss of the inner retinal barrier, which causes exudates, and that is the yellow component. So you will see both in an exudative RD. Carry on.
1 second. Is there any quantitative measurement to like say this is more flare, this is less, something like that? Is there something like that? Akarsh or Vinasni? Sir, exam questions. Yeah. Can you quantify? Yeah. Can you quantify it?
Yes, sir.
What
Depending
is-
on whether how much of the iris details are visible.
No.
That is grading.
No. That is what we see, right? Is there any instrument that can measure these, proteinaceous materials in the AC?
So laser flare photometry is one where you can actually measure. So these are exam questions, purely ask you.
This is the B-scan image of the right eye. The axial length in the right eye was found to be 24.72 mm, and the peripapillary choroidal thickness in the right eye is 1.85 mm. Here you can see the vitreous has some dot echoes. Posteriorly, you can see this is the choroidal layer, and here there is a detachment of the retina, and there is a corresponding high reflective spike in the A scan. This shows that there is a retinal detachment, and this is the temporal scan. showing the infratemporal quadrant, there is a detachment of the retina corresponding high spike. This is a high reflective membrane, and on sitting position you can see there is the shifting of the fluid, and it is not appearing where it is seen, and it has been shifted. So this is a sign of an exudative retinal detachment, where you can see the shifting fluid in case of ultrasound.
So what is the most important thing that we see in ultrasound? So whenever you, so I don't know, you might be a VR fellow or something. So what you, if you're going to sit in your ultrasound room and do ultrasound for such case, what do you look at? 1, 2, 3. So it's not just ultrasound, RD. So RD was there in the previous case as well, right? So what's the difference between this ultrasound and the previous one? So what is the most important thing that we see? Yeah, Sam? No, those are for the RD. RD is there. I know. Yes, this is an RD. So what extra details does this ultrasound is going to provide me?
So the extent of RD
Okay.
and the shape, contour.
All those things can be seen clinically as well, right? So why did I do this ultrasound in this patient?
Underlying choroidal detail.
Okay, choroidal thickness. I agree. What else? Most important thing. Dr. Shankar, can you? Okay. To assess the treatment, yes, I do agree. What is the most important thing?
After movements.
So what is the first scan? Why did we do that?
Axial scan to see the optic nerve attachments.
So what is it?
Differentiate between RD and CD?
No, not really. So here, I know this is RD, right? So what is the first one showing? T sign. T sign, yes, no. Okay, presence of posterior subtenance fluid. Okay, that is the most important thing. So whenever you are doing ultrasound in a patient with exudative RD, always remember to mention whether the T sign is present or not. Okay, otherwise the scan is incomplete. Okay. Anything else?
What is T? So it is, see, when you have fluid accumulation behind the eye. So so exudative RD is fluid accumulation within the eye, somewhere in, like behind the retina. So what is fluid accumulation because of? It is because of inflammation. Inflammation is nothing but what to say, when you have an injury, just imagine inflammation to be something secondary to injury. So when you have an injury, the fluid seeps in. So whether the fluid is seeping in just into the eye, or is there component something in the surrounding portions also, so the spillover. So when you have an inflammation in one area, the surrounding area also can have inflammation. So when you look at an exudative RD, you should try to find out the cause. So where all the inflammation is there, you should specifically know. So when you have inflammation outside the eye, how will you know? You will know only with the help of ultrasound. Without ultrasound, you will not know. In the ultrasound, what you will see is there will be fluid accumulation outside the eye as subtenon widening. Okay, when the subtenon widening is complete all around the optic nerve, it appears like a T in the axial scan. So it is called T sign. T sign is the advanced form of subtenon widening. Okay, so
and one more most important thing is, what's the age of the patient? Yeah, so it's around say it's a middle-aged. Okay, I mean it's an elderly female male patient, not 25, right? So what if the same thing happens in an elderly, say 60-70 years of old patient, comes to you with unilateral exudative RD and you do the ultrasound? So one thing I would see is, yes, all those things. And second thing is, yeah, I heard that answer. Yeah, mass lesion has to be ruled out. So again, commenting about these two things are very, very important in these cases. Okay, proceed.
Ultrasound image, we scan image of the left eye. Here the axial length was found to be 21.88 mm and periapillary choroidal thickness is 1.57 millimeter. And here you can see the IOL. Here you can see the lens echoes, and here there is a retinal detachment seen here, both inferiorly and then the nasal aspect. And on sitting position, you can see there is a shifting. Here there is no any obvious T sign, no underlying any mass lesion noted here. This is the right eye long scan image, SSOCT image of the right eye. Here you can see that the inner retinal layers are thrown into the folds, and there is a multiple subretinal fluid packets noted here, and these are the some PEDs noted. These are the PEDs, pigment epithelial detachment, noted below, and here there is also a characteristic feature seen. There is a bacillary layer detachment is noted. The bacillary layer detachment is nothing but the split at the level of the inner segment zone, that is myoid zone, is called as bacillary layer detachment. Actually, this is not the detachment of the neurosensory retina, and this is a bacillary layer detachment where the split is seen in the myoid zone.
What do you see in that vitreoretinal interface?
In the vitreoretinal interface, you can see some hyperreflective dots which suggest that there is an activity.
The dots.
Here.
Why do you say it is SSOCT, and what is the benefit of doing SSOCT? What does SS stand for?
It's web source OCT.
Okay. Why it's web source? What is the benefit of doing web source in this patient? Yeah.
Ma'am, the scan acquisition time is faster with an SSOCT. The frequency of the A scan is faster, so we can easily pick up the.
Is that why you do it?
What is the advantage, ma'am?
The SSOCT, I believe, has a greater choroidal depth, penetration depth, and the sensitivity of picking up the choroidal structure and is more, and also the horizontal width of the test, I suppose, is more than an STOCT.
The swept source is important in this case, not because it is fast. You can do a 3 millimeter OCT, which is very fast. The advantage here is the width and the depth, because you are asking specifically for a choroidal lesion causing the exudative arc. So when you mention it is SS, it is fast, it is good through a small pupil, but for this patient, probably that is not the reason why you did a swept.
And this is a long scan, is the swept source OCT image of the left eye. Here also you can see the similar picture. Here you can see the same hyperreflective dot echoes in the vitreoretinal interface, and as well as there is a bacillary layer detachment, and here you can see the septations, and this hyperreflective area seen within the bacillary layer detachment area are all are fibrin deposits, and here the photoreceptor segments is appear that there is some irregularity, and here these are the choroidal folds which you can see here. And foveal thickness, as you can see, there is a fluid accumulation. It's a 1804 microns is noted here.
So it is to appreciate this undulating choroid for a wide length of scan, and to appreciate the the halars and the underlying choroidal layers. We do SSOCT, swept source. It is only a documentation thing. Since we have it, we do it. Even if it is not for any exudative artery, if you have one investigation of choice, it will be FFA.
Yes.
So.
And this is just show you the difference between the normal subretinal retinal detachment and difference between the bacillary layer detachment. Here you can see the layer detached is beneath the external limiting membrane. Here you can see the external limiting membrane is here. The separation beneath this is a bacillary layer detachment. That is, here is the myoid zone, the inner segment of the photoreceptor where it is located. And this is the normal retinal detachment. Here you can see the detachment is below the ellipsoid zone. And this is the SSA image of the right eye. Here you can see initially in the initial phases there were very hypofluorescent areas, where the late arteriovenous phase you can see the hyperreflective multiple pinpoint autofluorescent dots noted here in the temple.
Hyperfluorescent dots. Yeah.
Hyperfluorescent dots noted here. Here in the late arteriovenous phase, you can see the pinpoint hyperfluorescent dots. It is increased in intensity as well as in the size, indicate that there is a leak. This is the corresponding ICG image in the which shows the corresponding. Here you can see clearly the temporal and near the arcade there is a pinpoint hyperfluorescent in case of FFA image. In case of ICG, you can see the corresponding areas appears to be hyperfluorescent, which indicates that there is an inflammatory area there.
So what are these pinpoint leaks? Anyone?
Is it capillary leakage?
So is it something? Is it a capillary leakage? Then why, like, even in diabetics, we do see these lesions, right? So what's the difference between these pinpoint leaks and the one which we see in diabetic patients?
So the intensity will increase in this.
See, in diabetic retinopathy, you have loss of the inner retinal barrier, and you have loss of the endothelium, and there are leakage. Over here, you are seeing the leakage points not on the vessels. It is elsewhere, right? It is not on the vessels at all. So these are breaches in the outer retinal barrier. So at the RP level. So that when you have breach in both outer and inner retinal layer, you will have multiple pockets of fluid which was seen in OCT. Ideally speaking, FFA should be shown first. Okay, so you have multiple pockets of fluid leaking from everywhere, both from the inner and the outer. So you will have pockets of fluid not just in between the neurosensory and RP. No, it will be there in every single pocket. It can come in any in between any two layers in retina. So that is why you see bacillary layer detachment. You can name hundreds, but the thing is the pockets is at every different level. So that is what an SSOCT over a wider length, it shows a beautiful picture of multiple pockets of fluid. So the white hyperfluorescent dots that you're speaking, pinpoint leaks, those are break in the outer retinal layer, and the corresponding black dots in the ICG, which mean in the choroid, these are called as HDDs, hypofluorescent dark dots. Okay, so HDDs on the choroid. Why HDDs on the choroid? Those are the inflammatory choroid. So to that area, blood supply is not there. The surrounding area, blood is there. Understand? So the active lesions in a choroid on an ICGA will look hypo. Okay, and if you look at only when you have ICG and FFA together, if the hypofluorescent dots coincides with the hyperfluorescent spots on the FFA, you can say that it is active. Even after the inflammation goes away, suppose this patient comes after resolution and I just simply do an ICG, I would be able to see those HDDs. But if I do a corresponding FFA, there will be no leak in the FFA, which means to say the dark dots are persisting, but they are inactive. Understand? So HDDs those are the active choroidal lesions, and the overlying retina, when it has inflammation, when the RPE has broken down, the fluid comes in, and that you see because your FFA picks up that leak. Understand? The ICGA doesn't pick up any leak or anything, it just picks up the lesions in the choroid, and activity cannot be told just based on ICG alone. You have to correlate it along with the FFA, and then you will be able to tell whether it is active or not. Next.
Similar lesions.
This is similar lesion in the left eye, but here you can see as there was some hyperemia and the disc edema, you can see the disc leak is noted in the left eye. The same way, the pinpoint leaks intensity and size has been increased, and corresponding hypoautofluorescence is seen in the ICG.
So once again, what are the other causes of Ballard? Any seniors, any PGs can answer? Ballard, bacillary layer detachment, other causes. Yeah, of course. VK, of course. Other causes. Yeah, okay. Both are same. Any other vascular conditions can lead to this bacillary layer detachment? Okay, not really. No, not really.
ARMD,
Yeah. Who's that? Who answered? Yeah, that's great. Which ARMD?
Vet, sir.
Okay, can you be more precise? So PCV. Okay, PCV patients
Okay,
can
sir.
have, may have actually. Okay, proceed.
Then the investigations are serum ACE and serum ACE, RPR and TPHA and QTB all were found to be negative, and hence the working diagnosis of bilateral exudative retinal detachment and probable etiology being VKH has been made. Management is intravenous
So
methylprednisolone.
just a minute. So in this patient, actually anterior segment was quiet. AVF no cells. Only the posterior pole had multiple pockets of pockets of fluid. This is not an exam case. Okay. The first thing that came to my mind when I saw this picture was multifocal CSR, because there is no other signs of inflammation. VKH, as you know, is a pan uveitis. Okay, this case has been put only to because in a VKH patient, when you go and take FFA and ICG, the photos will not be clear because of the vitreous haze and then anterior segment, all these things. Only the ultrasound will be very clear. This is a probable case of Haradas. Harada is nothing but is one of the spectrum of VKH, in which only the posterior this thing is there, and I believe the trauma history was really insignificant. So this in Haradas you only have the posterior component of the disease, but these are not exam things. But I'm just telling, this case comes to you in exam, exudative RD bacillary layer detachment, you will be talking VKH only. Okay, but in examinations, this is what we found in this patient. The classification criteria for VKH is 2-3 things. First thing is rule out trauma. The last thing in the classification criteria is rule out sarcoid and syphilis. And in a country like India, we rule out TB as well. So after these two things, the remaining criteria is the actual classification for the VKH proper. So you will have exudative RD, you will have pan uveitis. It should be bilateral. It should be it can be granulomatous, and you can have associated tinnitus, skin lesions, neurosensory problems. So of these 5, if more than 3 are there, it is probable. So this was a probable VKH, and it was not full-fledged VKH. It was a spectrum, only Haradas. So but the treatment is still the same. Okay, next.
Management is intravenous methylprednisolone 1 gram for 3 days as given, followed by oral prednisolone weekly tapering dose, and tablet azathioprine 3 times daily for 1 month, followed by tapering for 2 times daily, and along with the antioxidant has been given twice daily. After 10 days post treatment, the vision has been vision in the right eye was counting fingers at 2 meter, and the near vision was less than N36. Here, this is the old image. You can see here. It is resolved.
So this is not even 1 whole month. This is just 10 days post treatment. Understand? So he was called just 10 days post treatment because I wanted to know whether the drug is working properly or not, and this was just for a documentation purpose. And if you look at go back one slide, no. So there is no point in treating an inflammation half-heartedly. Okay, any inflammation in the eye, when it causes when it results in a scar, means it is a permanent scar. It can be even a very simple visual field defect, which you won't even find. Only when he does an HUF, you will find, okay, there is some visual field defect. So any inflammation, when it comes and goes, whatever damage it has created is a permanent damage. So your treatment, don't start 40 mg steroid. Even when you go out, never do a half-hearted work. Inflammation is there, pan uveitis. You have seen the FFA and you see how aggressive it is. Go ahead, treat it fully aggressively. aggressively, and then you slowly taper off. So it is because you are giving aggressive treatment, you need to get a physician opinion prior. Check whether his do investigations before doing a steroid cover. The investigations which we do for steroid covers include anybody? Sir, oral steroid and IMT package. No, that works only in SN. Outside. In exams, they ask you what is the test before doing oral steroid and IMT. Practicals, they can ask you. Huh? Quantiferana. No, that is not mandatory, no. I don't suspect. This is a case of leave leakage. Case of sympathetic ophthalmia comes with a history of trauma. I want to start steroid for this patient. Is QTB? QTB is for me to. It is because we are in SN, we are ruling out other things to make sure. Yes, this is tomorrow. If I put it among 300 cases of VKH, nobody should come and question me saying, "How come you are telling me this is surely VKH?" Documentation. You want to do a research, documentation works. You are outside in a secondary healthcare center. You cannot ask every patient to do a QTB. It is a clinical diagnosis. VKH again is a clinical diagnosis. Right? So, my question is very clear. If you want to give oral steroid and IMT for a patient, what all test do you do? CBC?
HbA1c, RBS, urea creatinine, chest X-ray.
HB, TC, DC, ESR, platelet count, urine routine, stool for occult blood, then FBS, PPBS, HbA1c, urea creat, and if I want to do IMT, then I have to do LFT. Understood? So urine routine, stool for occult blood. So these things, these are not blood investigations, but still you need to do. Urine routine, still not a blood investigation, but still you need to do. Okay, presence of urine protein, presence of urine sugar, again tells you the status of the patient's physical condition before you give IVMP. And IVMP, though we give it in our in our wards so frequently, but it has, why do we give it in ward? It is because it has its own, grave effects. So it has to be, the patient is kept under monitoring, and we do this IVMP. All right, and then after IVMP, and then you slowly taper off steroids. And when to give immunosuppressive therapy and how to taper immunosuppressive therapy is the art of following up the patient. It is not just starting the treatment. Starting the treatment can be done by anybody, but following up the patient after the initial, the earlier the treatment is started, better is the prognosis. Following up the treatment and keeping the patient on adequate treatment is the art of managing the patient. Okay, and antioxidant management will be discussed in subsequent classes. Antioxidant tablet, why? It is again in the same slide. The RP pump, it has to work. Inflammation. When you have inflammation, you have photooxidative stress. Back to your second years. Okay, so to reduce photooxidative stress, to keep the RP alive, to prevent damage further in the retina, you keep the patient on antioxidants. Load the patient. That is why antioxidant 2 times a day over there. Right? Okay, next.
This is the same left eye image.
Yes.
After 10 days.
Bye.
10 days post treatment, the vision was improved to 6/24 in the left eye. Near vision improved to N18. And here you can see the ballad has been resolved. And here the sim disc edema and some SRF is still present. Case.
What are the causes? What are the causes of other causes of exudative retinal detachment? Yeah.
The causes may be idiopathic and any vascular lesions and optic disc anomalies and degenerative conditions, any tumor, underlying choroidal tumors, any malignancies and inflammation, and following infection also exudative RD.
Once again, so can exudative detachment be iatrogenic? Any of the senior PGs? Please answer into your mic. Please. Take your mics. Who's having the mic?
Yes, sir, it can be.
Yeah. Causes?
So post like excessive photocoagulation
Yeah.
or cryotherapy.
Yeah.
Like
Fantastic. Great.
patients can-
Great. That's a nice answer. Can proceed.
And case 3 is a 54-year-old male came with the complaints of both eyes gradual diminution of vision since 6 months and floaters for past 2 months, and a history of dust particle fall in the right eye 1 year back, and he noticed the diminution of vision since then. He also had a history of injury to the head in the occipital region 10 years back, but no any loss of conscious or vision complaints following that. He's a known case of severe with right hemiplegia since 8 months, known case of diabetes mellitus for past 10 years on medications, and known case of tuberculosis lung for 3 years and hypertension for 2 years, and he has been recently diagnosed as a chronic kidney disease. And clinical examination, best corrected visual acuity in the right eye is 660 and 618 in the left eye. Near vision is N24 in the right eye and N12 in the left eye. His Hirschberg's are found to be ortho. Extraocular movements are full and free. No abnormal head posture. Pupillary examination was normal. No RAPD. Slit lamp examination of the right eye showed normal anterior segment with early lens changes and pigment in the anterior lens capsule.
Yeah. Hold on. So, in an uncontrolled diabetes patient, what are the corneal changes that you expect? Yeah. One is recurrent epithelial erosions. Yes. What else? How is the corneal sensation in a patient? Yeah, it's reduced. Okay. Oh, okay. Yeah, sure. You can proceed. So one thing is, you can proceed. We'll discuss.
Intraocular pressure in the right eye is found to be 18 mm Hg and left eye is found to be 14 mm Hg. And it is the pseudochalatic optus image of the right eye and the left eye. This is the right eye. Here you can see the media appears to be a little hazy and the disc is hazily seen and margins are not clear. And there is fibrous proliferative tissue seen extending from the disc.
So you have to go from the back to the front. It's always good to describe this image from the vitreous. So what do you see in the vitreous in this patient? So yes, you said the media is hazy.
Yes.
What else? Can you point out that in the OD? Yeah. What is that? Yeah, a streak of blood is. Yeah, that's a pre-retinal hemorrhage. Yes. So next, and then you can proceed. You can proceed describing the retinal findings.
Okay. So in the retina, you can see the dot blood hemorrhages seen here. And there is a proliferative.
And one more suggestion is, once you describe the vitreous phase, you can describe the findings in the posterior pole. Then you can go, to the regarding the traction. Then you can describe about the peripheral findings. So this is how a good order should be, so that you don't miss anything. Okay. Yeah.
Multiple hard exudates are seen around the macular region and nasal quadrant inferiorly. And there is here the fibrovascular proliferation is seen extending along the arcade superiorly and also inferiorly. And here dot blood hemorrhages are seen near the disc nasally. And this is the cotton wool spot seen at the very first.
Not really. That's not a cotton spot. Okay, fine. So what are hard exudates? So very basic question. Any of the first year can give the answer. Which layer do they correspond to? So which layer do hard exudates correspond to?
Outer plexiform.
Okay, fine. So she was telling something about the dot and blot hemorrhages. So which layer do they correspond to?
Fiber layer.
Okay. What about the cotton wool spots then?
Fiber.
Yeah. So then what about the dot and blot hemorrhages? And why do these hemorrhages, why do these hemorrhages look in that shape? Why do these hemorrhages called dot and blot hemorrhage? Why are flame shaped hemorrhages, flame shaped? Yeah, because of their arrangement, right? Yeah. Can proceed. Please proceed. These are very, very basic questions. One must be, thorough of these. Yeah. Please proceed,
This is the
Madhumitha.
after pseudocolor image of the left eye. Here the media is hazy. Disc is also seen hazily. Borders is not clear. And here you can see inferiorly there is a preretinal hemorrhage noted here, and there are multiple hard exudates seen in the periphery as well as around the macula, and there is a fibrovascular proliferation seen superior to the disc along the arcade. And this is a OCT image, SSOCT image of the right and left eye. Here you can see that hyperreflective dot echo seen in the vitreoretinal interface. And this is, you can see there is the retinal detachment which appears to be concave. This is because of the traction. And the SRF is not clear, and there are some multiple hyperechoic foci seen. This is hyperechoic foci also seen in the outer plexiform layer, and there are multiple hard exudates also noted. Then in the retinal layers, you can see the schisis of the retina is also present.
The one which you told as an SRF?
This is schitic area.
Not really. Okay, you can proceed. Sure. Next slide, please. Okay.
The management is actually, the diagnosis is bilateral proliferative diabetic retinopathy with tractional retinal detachment threatening the fovea. The treatment given was both eyes pan-retinal photocoagulation, 3 sittings was done, and then this is a differences between the rhegmatogenous tractional and exudative RD. The more common type among the three is the rhegmatogenous RG. The most common, we have to ask for history of any history of myopia, blend trauma, and it may also be followed by any PVD, and pre-existing retinal degenerations we have to examine, which is predisposed to rhegmatogenous RD. In tractional RD, the most common causes are any history of penetrating trauma, ischemic or venous occlusive disease, prematurity, and sickle cell disease. Cause of exudative RD, it may be idiopathic, vascular damage, optic disc anomalies, degenerative conditions, any choroidal tumors or malignancies, inflammation, and infections. A retinal break is seen in case of rhegmatogenous RD. In tractional RD, secondary to traction, the secondary break may occur. Then the extent, usually it extends from the ora serrata and up to the optic nerve head. You can see the optic nerve head attachments in the B scan. In tractional RD, it does not extend usually up to the ora serrata, and its exudative RD, it may be variable depending upon the mass or lesion where it is located. All these lesions, it may be located anywhere in the central or peripheral. Then borders, if you see in the rhegmatogenous RD, it is a convex, and tractional RD you have seen as there is a traction over the retina, you can see there is a concave surface. And exudative RD is also a smooth surface, and it is volume and gravity dependent. Then retinal mobility, in case of rhegmatogenous RD, it is an undulating bulla or folds you can see. Tractional RD, because of the traction, the retina is very taut, and at the traction points, there is a peaking will be noted. And in exudative RD, there is a smooth elevated bulla, no folds are seen. And subretinal fluid is clear in case of rhegmatogenous and tractional RD, and turbid in case of exudative RD. And in ultrasound, you can see the shifting of the position on sitting and lying down position. Then in chronicity, in case of rhegmatogenous RD, in chronic RDs, there may be development of demarcation lines, intraretinal cyst and atrophic retina is noted, and in tractional RD, demarcation line will be seen. Then pigments in the vitreous are more commonly seen in rhegmatogenous RD because for the RPE to reach anteriorly, there should be a break. So it is seen mostly only in the case of rhegmatogenous RD. And vitreous changes in rhegmatogenous RD, there is a vitreous syneresis and posterior vitreous detachment will be there. And in case of tractional RD, there is a vitreoretinal traction which is causing traction in the retina. And exudative RD, the vitreous usually will be clear unless in case of any uveitis or any other VKH, like we can see any cells and vitreous haziness. Intraocular pressure usually will be low in case of rhegmatogenous RD, as we have discussed earlier, and in tractional RD it is normal, and exudative RD it may vary. And ultrasound features, you can see in the rhegmatogenous RD, it is a high reflective membrane, as we discussed earlier. Sometimes the break areas may be seen, and it is a high corresponding A-scan spike will be noted. And on examining with the movements in the ultrasound, we can see poor after movements. In tractional RD, it's also a high reflective membrane, and corresponding high spike A scan will be there, and here also it will be the poor after movements. In exudative RD, it is a smooth surface dome shaped hyperechoic lesion, and it varies in position, and it may be mobile, and it is associated with choroidal thickening. If there is any mass or tumor, there will be underlying choroidal lesion will be seen. Whereas to differentiate from the PVD, these all are retinal lesions, so there will be a high reflective membrane. Whereas in case of PVD, it will be low reflective, and in A scan also, you can see the spike will be very low, and it is highly mobile when compared to all these. This is a summary table of what we have discussed now. These are my references. Some acknowledgements to be understood. Thank you.